Okay, in this class we will talk about drug distribution and protein binding. And again, it's just the basics related to each part of it. We used all the time before talking about the distribution of the drug as just a kinetic process or a process that the model that we are talking about would depend on the this main kinetic process. Okay, we know that it's a reversible process in which the drug is transferring either to or from the site of the measurement. So many factors affect the drug distribution. We will talk about the different tissue characteristics, disease state, the solubility of the drug mainly in lipids because we are talking about membranes, and regional differences in physiological pH because it's affect the ionization of the drug, and the extent of protein binding, okay, which is something that it's very important in kinetic because it's affect so many processes either in the distribution process or in the kinetic elimination process, okay, elimination kinetic process. In this slide we are having a summary of whatever you know about the aqueous or liquid or water compartment that we have and the body. So if we are talking about distribution only and the water compartment, we know that this would include plasma, sometimes would be in blood cells, or either an overall body fluid that would reach 43 to 45 liter of an adult male with a weight of 70 kg. But this is not usually the case, and we will see why we don't have just a distribution or a volume distribution that includes or similar to the water compartment volumes. In the distribution, which is something you already know, we know that the process of the transport or the transfer or the uptake through different membranes would affect the distribution, and we have different pathways. It could be paracellular between cells or transcellular through cells. We may have passive diffusion for the majority of the drug. We may have active transport, which the active transport could be efflux transport or influx transport, which is energy dependent. We may have endocytosis or exocytosis, which again usually it's energy dependent. We may have some carrier dependent transport, which is not energy dependent. We have so many transport or uptake pathways that would affect the distribution at the end as a kinetic process. That's why we need to study each and every one of them for each and every drug or active metabolite. So in the distribution models we had before, if you remember, the perfusion limited distribution and the permeability limited distribution. And from the name, perfusion limited distribution, so the rate limiting step is the perfusion, or what we had the symbol for it as Q. So it depends mainly on the blood flow to the tissue that we are interested in. As the higher the perfusion to the organ, as higher the distribution to those organs. As lower the perfusion to those organs or tissues that we are talking about, the lower the distribution, because it's the rate limiting step and the distribution. Okay, again, as the perfusion is increasing, the time for the drug to reach the distribution equilibrium is decreasing, because we can reach the distribution faster because the perfusion is higher. Okay, so we can see here in the diagram, if we are talking about the blood capillary, interstitial fluid, cell membrane, and intracellular fluid. If we are talking about the flow, then we are talking about this only, and we don't have any problems at this membrane or at these membranes before reaching or entering the cells. Okay, so the membranes that we have in here are not the rate limiting step of the distribution. That's why we usually have an easier equilibrium between the blood and tissue to be reached. That's why sometimes if we don't have any problems in the permeability, we can have a rapid distribution, and that's why we can have a behavior that is similar to one compartment because we have a rapid distribution. Okay, when we are having the permeability limited distribution, again from the name, the rate limiting step is the permeability, which means that it's not the perfusion, it's actually other stuff related to the permeability or the transport of the drug through different membranes or tissues. Okay, for example, and those are examples that you already know. If the polarity of the drug increases and we are interested in the permeability of that drug to blood-brain barrier, which is one of the main lipophilic membranes in the body, so it will be decreased. The partition coefficient increases, which means that the permeability through membranes, which is lipophilic in nature, would be increases. And again, this is under the assumption that we are talking about the permeability through membranes or passive diffusion, because in other cases, such as the active transport, the other factors would affect than the factors that we know that is related to passive diffusion. Ionization of the drug. As the ionization of the drug increases, then the permeability usually decreases. Molecular weight, as it increases, the permeability decreases. And again, we are talking mainly here about passive diffusion of the drug, not about each and everything. Okay? If we are talking about those kind of, let's say, rules of thumb related to the physicochemical properties of the drug, so we can say in a way or another, if we are having small, which means that we have low molecular weight of the drug and it's lipophilic, so we don't have problem in the size or the penetration into tissues, then it's mostly a perfusion limited distribution. But if we have large, so the molecular weight is large and hydrophilic, which means that we have problem with the transport or permeability through membranes, so it's usually permeability limited distribution. This is or those are general concepts or general ideas of the transport or distribution or the effect on permeability, but we know that we have case-by-case condition that would either the characteristic of the drug affect the transport, or either we have active transport or carrier-mediated transport. So each and everything needed to be taken into consideration. Example, as a diagram, we don't have, again, a problem in the flow or the perfusion to the organ, but we have two membranes to consider, either the capillary membrane or the cellular membrane. So we may have rate limiting step of the transport through the cellular membrane. Okay, so then the transport would be permeability limited at the cellular membrane, or either we could have it also at the capillary membrane too, which means that we have both of them. So it depends, but in both cases or either cases, the permeability is through the membrane is low, and our membrane and permeability across them are the rate limiting step. That's why we are having it as permeability rate or permeability limited distribution. And as the equilibrium won't be reached, distribution equilibrium won't be reached fast compared to the perfusion limited distribution. So that's why we have time, more time, or the distribution equilibrium will be reached slowly compared to the perfusion limited model or perfusion limited distribution. That's why we can't view them as one compartment. It's actually would be two compartment or different compartments, because we need time because of those membranes to reach the distribution equilibrium. Okay, the disease state effect on the distribution. We know that different disease or disorders would affect the physiology of the drug and different kind of physiological processes. Example, if we are talking about, let's say, heart failure, hepatic failure, or renal failure, the cardiac output to those organs or to certain organs would be affected. If we are talking about heart failure, then the cardiac output to different organs would be affected. So if the perfusion to certain organ is less, then the distribution to that organ would be less, then the concentration of the drug in this tissue or this organ would be less. If we are talking about just distribution to that organ. If the drug, if the tissue is eliminating organ, then less perfusion to the eliminating organ means we will have less drug elimination, because it's we have less perfusion to it, and then more accumulation of the drug or the entity that we are talking about in the body. So it's just one disorder or many disorders that would affect the distribution by just changing one thing that is related to the perfusion. Okay, the lipid solubility, now the majority of the concepts in the lipid solubility, because we know one that the membranes are lipophilic or lipid in nature, so we need certain level of lipophilicity of the drugs to go through the membranes. If we are talking about the common case of the transport or distribution. Okay, so usually we consider the lipophilic drugs penetrates easily through membranes, so and they go into lipophilic tissues such as fat or adipose tissue, and it would be the opposite for any polar or hydrophilic materials. This case, or the idea of the lipophilicity of the drug, or its hydrophilicity or lipophilicity of the drug, would affect the distribution of the drug, even if we are talking about the same drug, but in different patient condition, such as, and we will see this in the drugs groups, such as the, let's say, the normal weight individual versus overweight individuals versus underweight individuals. Okay, and the overweight, we are having more fat or adipose tissue, which means that the dose calculation here, we have the normal percentage or weight, let's say, of the fat tissue, and here we usually have only lean body, which means that we don't have that much of the fat. Okay, so accordingly, if we are talking about whatsoever each one of them, then the dose calculation should be taken into take into consideration the fat percentage of that individual that we are talking about. Okay, and again, it's usually we have general guidelines for different groups of the drug according to the kinetics that we know about it. If we are talking about lipophilic drug, which means that an overweight patient, it means that it will go more into the fat tissues compared to hydrophilic drug. So usually, if the drug is going through, because it's lipophilic, to the adipose tissue, then we need to do that correction, which is which is needed to take the and here usually what I'm saying here usually in general the volume distribution is based on the ideal weight for drugs that do not distribute into adipose tissue, which means not the lipophilic drug, and total body for drugs that do distribute to adipose tissue. We are talking about volume distribution, but for the VD calculation, we will have again equations that take into consideration if the drug is lipophilic, then we need to take into consideration some adjusted weight or adjusted. We have three kind of things. We have the ideal body weight. We have the lean body weight, which is the normal, and we have the adjusted body weight. And each one of them, we have the correction according to the kinetic of the drug and the drug that we have, either if it goes into the adipose tissue or not. So if we are talking about a drug that goes into the adipose tissue, we need to take this into consideration. And if we don't have a drug that goes into the adipose tissue, then we can just use the ideal calculation that we have as a general guideline. Okay? And we will see this in calculation when we go into the drug groups. Okay? For the regional differences and the physiological pH, we know this as the pH partition theory, Henderson-Hasselbalch equation, and we know everything that is related to the ionization of the drug, either it's weak acids or weak bases, okay? And we know that to have more of the non-ionized, which is in this case for the acids and lower part of the equation, then this will be preferred at lower pH. Okay, again, if we are talking about only one side of the membrane, okay, and the bases would be the opposite, this would be at higher pH for the bases. Okay, so as a general rule, we are talking about unionized drug at physiological pH to cross the membranes, which is 7.4 or near 7.4 is a pH. And again, this is a general rule because if you had Zwitter ion, this again considered as neutral, but it's still ionized. So there's a lot of things to be taken into consideration. Okay, there is a directional diffusion of the drug that is related to the pH differences at both sides of the membrane, which cause an accumulation of the drug at the side that prefers or favors the drug ionization. And what is that? We will talk about this in a minute, but for the passive diffusion effect of the pH on the passive diffusion on this slide, it's whatever you know here or I just mentioned here. It would be for acids preferred at lower pH, and for bases would be preferred at higher pH. The transport, because the fraction of unionized, the fraction of unionized is more. Okay, that's why okay, that's what we have, and the already if we are taking into consideration a difference in the pH at one side of the membrane. Okay, so you have nothing to take care of at this side or any differences at both sides of the membrane. If you are talking about the directional diffusion or differences across the membrane and the pH, for example, we are having 6 pH here or 7.4 pH. Let's say here the apical side or A side, and this is the basolateral side or B side. So this difference and the pH would have different ionization of the drug at both sides. And you can do the fraction of unionized of the drug at each side of it to know what side of the membrane prefers the ionized or ionization of the membrane. And this is the general case here. The acids are trapped, ions are trapped at the side of the higher pH, okay, because the ionization is higher, and the bases, ions are trapped on the side of lower pH, which because the ionization is higher, okay. So it's different than what we were mentioning here because we were talking about one side only here. So if it's bases or not according to the diffusion, okay, passive diffusion. But in here we are talking about one other factor involved, that if the drug is moving from one side to another with different pHs at both sides, what would be the effect of the movement of the drug? And we know, or we notice, that the ion trapping or the directional diffusion is not that clear in vivo compared to the in vivo compared to the in vitro experiment. And when we are talking about in vitro experiment, we are talking about cellular or this cellular level, in which, let's say, we have cells here, and we have A side here, and we have B sides here, okay? And we are doing the experiment, so it's easier to have this effect shown in the in vitro compared to in vivo, such as the animal, let's say, kinetic or drug distribution, okay? Why is that? Think about it, okay? The extent of the protein binding, we know that for the protein binding, as a general case that you already know since ever, that the unbounded drug, which is either the unbound, fraction unbound, or the free fraction of the drug, it goes through the membrane, and also the free drug that is thought to have the pharmacological effect. But still the drug, let's say drug plus protein reaction is reversible to give us the drug protein complex, okay? So the association and dissociation reaction between drug and protein are rapidly reversible. That's why the equilibrium usually rapidly shifts two sides, depends on the case that we have, okay? We have different plasma and tissue proteins. One of the major protein in the plasma is the albumin. After that, alpha-1 acid glycoprotein. And then we have lipoproteins, which each one of them interact with different, with drugs with different characteristics. We have other specific proteins such as sex hormones, cortisol, globulin. So we have different protein in the plasma, and the same thing we have in tissues. And we have and here, first of all, I said this is the main protein, and this is clear here with the concentration of the albumin, for example, compared to the acid glycoprotein, okay? And here showing you that each one of them binds to different drugs with different characteristics or nature. And as we have different proteins in the plasma, we have also different proteins in tissues, and the binding of the drug here or there depends on the characteristic of the drug and the affinity of the drug to this kind of protein. In this slide, we are showing only that the transport or the distribution of the drug or the elimination of the drug or the clinical response of the drug depends on the status of the drug in different spaces, physiological spaces. Let's see, starting with the plasma, we have protein binding, let's say, and we can find its reversible reaction in the free drug only that goes either to tissues or the eliminating organs such as kidney and liver. Okay, and the tissues, we need the drug to bind to the receptor or the active site or the biphase to give us clinical response. So see the difference here, we needed the free drug to be transported or distributed, but here we needed the drug to be bound to give us the effect. And the eliminating organs, and the liver, the drug will bind to the enzymes, and again to give us the metabolite that would either be excreted unchanged in the urine or in the bile, which is here it's the metabolism of the drug. Okay, and also here we have the kidney, in which the drug could bind to carrier to have the active secretion, or just by remember we have glomerular filtration, tubular secretion, tubular reabsorption, and it depends on the case if it's active or active and passive or just passive. And we may have also just without binding excretion and the urine. So we have different ways of thinking about it, okay, in which we can, I just noticed that this should be, okay, forming our metabolites. Okay, and so it depends on the binding status of the drug, either with protein, we are talking about protein, okay, in general, and the plasma, that we need the drug to be free or unbound to be transported or distributed, and this is what we can see here, okay. We know the binding to the receptor, and which is give us what we call it the pharmacodynamic of the drug. And in the excretion and metabolism, we know so many things about this, either if we are talking about metabolite formation and then excretion of it, or just the excretion of the drug through different processes that we already know earlier from basic kinetic. Okay, the factors that would affect the transport, the extent of protein binding depends on the factors that would affect the extent of protein bindings or include many factors. The factors would include many factors. The what would affect the protein binding, we have many factors in them, such as the concentration of the drug, the protein that would bind to that drug, the affinity and the presence of other drug or entity or inhibitor or inducer that would bind to that protein. And here I have an animation for that. In which we have the drug concentration, if we are considering our drug of interest is A, and then the protein, how much they have affinity to each other, and then the presence of other drug that would be inhibitor, would be inducer, or would be just substrate, another substrate for the same protein that would affect that affinity of the drug. So those factors should be taken into consideration to define the nature of the protein binding and how much would affect the distribution of the drug. Okay, So we can't just say if we have protein binding, then the distribution of the drug is less than it should be. Okay, we have here the effect of protein on the concentration, protein concentration on the drug concentration, and we have an example for that as a phenytoin, which binds to albumin. Okay, and we have in the normal case, and again, this is the effect either of the disease on the protein concentration and accordingly on the concentration of the drug. So in the normal case, we have the free, let's say it's not a fraction, it's a concentration. The total that we have is 15. In the normal case, we have 1.5 milligram per liter of phenytoin as free. Okay, in hypoalbuminemia, which is a case in which the albumin concentration is decreased. Okay, which means that by default, the concentration of the free and bound drug would be more. So rather than 10% of the total, we have higher free drug, which is reaching 20% of the total. Okay, and this could happen in hepatic or renal function or other disorders. And by having this issue or this kind of difference related to the decrease in the concentration of the albumin, the free concentration or unbound, it's the same, of the drug is increasing, which means the effect of the drug would be higher than it's expected, which means that the side effect of the drug would be more. So we need, again, if we know that we have this, okay, or we just have our test and we know that we have this, we need to do some adjustment to prevent any problems, especially in drugs such as phenytoin, because it would affect the patient that we are taking care of seriously. Okay, and this would happen also for acid glycoprotein, in which the concentration of the glycoprotein would increase in some cardiac disorders or issues. We can determine the fraction of the bound drug and the unbound drug or free drug if we know the total bound in unbound concentration for sure by having the ratio, and we know that the ratio is part over total. So the fraction that you are interested in should be, if we're talking about bound, this would be bound over total. If it's unbound or free, then this is a free unbound over total. Okay, this is an important slide because I'm just emphasizing that the extent of the protein binding, it's not a consistent predict for the tissue distribution or half-life. Why? Because I know that we kept saying that if the protein binding is higher, then the distribution is less, which is a general case, okay? But you were not that into the details. We didn't go into the details of the protein binding and factors that would affect protein bindings other than just protein binding in general, okay? So we have so many drugs with high fraction of the drug bound, okay, but still have a good tissue distribution or penetration into different tissues. So all factors we mentioned in this slide should be taken into consideration: drug concentration, protein concentration, affinity, and the presence of other drug in addition to inter and intra-subject variability that should be taken into consideration. Okay, for example, we have drugs, and again, overall, the implication of the protein binding are not fully understood with not fully clear guidelines or clear, let's say, rules. But for example, we have warfarin, salicylate, phenytoin. They are highly protein bound, but we still have distribution of those drugs. Okay. I will talk about the volume of distribution physiological model in the next